Hello, my name is Harsha Shantana, and I'm here with Dr. Michael Stanton-Hicks, who served as president of ASRA from 1989 to 1990, and also received the John Bonica Award in 2017 by ASRA. This interview is part of the activities surrounding the 100th anniversary of the founding of the first American Society of Regional Anesthesia in 1923 by Gaston Labat and colleagues. Although this organization is not related to the current day ASRA Pain Medicine, which was founded in 1975, it has been said that the current society would not have existed quite like it does without the work of Dr. Labat and the original ASRA. So, dear Dr. Hicks, thank you so much for agreeing to be participating in this interview. And it's an honor for me to actually speak to you on behalf of ASRA for this interview.
Yeah, thank you for inviting me.
What was the path of events that led you to become president of ASRA at that time? And what obstacles did you have to overcome to serve, and advantages did you have around that time?
Yeah, it's actually a long, convoluted story. When I left Australia, I ended up in Sweden working with an Englishman, Peter Lee, who really was the first to induct me into the regional anesthetic procedures. So that when I came to the United States, and it was in particular to the University of Washington, because I wanted to work with John Bonica, he then just continued to teach me how to do these procedures and how they could become a part of pain management. So that's really the background of my regional anesthesia induction. So that by the time I had gone to my own department in Worcester, in Massachusetts, I had already introduced regional anesthesia to the intraoperative and postoperative areas. So that was really the background. It was in 1976, I had a funny telephone call from Harold Caron, the name of which I knew, but had never met. And anyway, he said, we've formed a new society. It's called the American Society of Regional Anesthesia, and it's a follow-on from Gaston Labat's society of the same name. He said, you must join this. And shortly after that, where we chatted a little bit, then he hung up. So that was my intro, if you like, to ASRA. And from then on, of course, I went to every ASRA meeting, and I organized one of the meetings in San Antonio. And then I was fortunate enough to be selected after Jordan Katz to become the president of the society. So that's the sort of the background why I ended up in that position.
Thank you. And I think since then you have served in the board for multiple years and providing valuable contribution to ASRA. What was the predominant issues of ASRA at the time of your association?
I think we were already, the board was always a little bit splintered. It was very active, quite dynamic, very forceful individuals, each one of them, and no one was more vocal than another. But there was some of the people like Raj and Winnie, to name just two, were more interested in ASRA becoming not just a, if you like, a block society, just a society for regional anesthesia and blocks alone, but it should be involved in pain management. And so this was if you like, a leitmotif that ran through my presidency. I don't think I was particularly responsible for any specific new aspect of the society during that period, but I was very strong about increasing our education of the membership into the extension of regional anesthesia as just the use of nerve blocks for different procedures, but also that there should be a strong movement to incorporate this into departments of anesthesia around the United States. When I was first interested in this, probably, well, when I first went to my department, I think there were probably only 5 or 6 departments of anesthesia in the country that had any respective regional anesthesia aspect. And at the time that I was president, of course, Prithvi Raj had already begun the pilgrimage around the United States with roving bands of anesthesiologists going everywhere to teach people on the weekend how to do this. And there were some very enthusiastic individuals. Al Winnie, of course, who, together with Danny Muller before he died, founded the Danny Muller Foundation, and that became an educational resource, which together with ASRA combined to extend the education of regional anesthesia to a much broader sense, not just providing relief of acute pain for a particular condition, but its incorporation into the operating room as an anesthesia service, post-operatively for acute pain care, and also in chronic pain, not the primary, if you like, not the primary instrument for managing chronic pain, but rather as a very important component in the diagnosis and particular aspects of pain management. So these were the areas that I probably concentrated most on during that year.
So you mentioned about the anesthesiology departments across the country, and people from ASRA like Dr. Raj and others going around. So do you think the departments around the country were responding to what ASRA had to offer, including for, let us say, pain medicine as a growing specialty at that time?
Yes, I think there had been an approach. I'm not quite sure when the first approach was with the American Society of Anesthesiologists, ASA, about being a component of that, or to have a separate society to maintain the separation of ASRA as a primary educational research and pain society. To add regional anesthesia service required the training of individuals, and there was a shortage of highly skilled individuals in regional anesthesia. It is a particular aspect of medicine that requires high skill, good anatomical knowledge. And we're talking about before there was anything like ultrasound to become our eyes in the inside of the body. But a good regional anesthesiologist was a good anatomist. And without anatomy, you couldn't safely perform these things and couldn't provide what we wanted to see in our patients. But I think, yes, there was an interest in starting up. And I think, thank goodness to ASRA as a society, it was becoming, people were beginning to listen at this stage. It had been operant since, what, 1975, and this was now 1989 during my presidency. So it had become a well-recognized subspecialty society in amongst anesthesiology.
So during your presidency around that time, do you think there were challenges? And if you want to elaborate on specific challenges that you encountered, and if you felt that ASRA did move the bar forward during your presidency, and if you want to highlight some of those, please.
The only challenges that I saw were those amongst ourselves. There were some who wanted to stay more in the regional anesthesia, the block mode, while there was a smaller group who wanted to move this. I felt that the society could not live alone on regional anesthesia. And our job as an educational society, we needed to provide the support to the departments where we wanted regional anesthesia to be opened up in the operating room and post-operatively. I think that those were the most difficult aspects during the presidency. There was nothing outside that I was particularly involved with in making any change.
So I think you have alluded to some of this, but my next question is more probably in a both personal and professional sort of sphere. When you were president, was there any particular person or organization that were more helpful? And how did you deal with your own personal assumptions or biases in taking ASRA forward?
Well, I had just assumed the ownership of a new department. I just moved from Europe, where I had been working in Mainz at the university, the university in Mainz in Germany, to a new position. So I'd only been in this position 10 months when I became president. So I had a conflict of interest on both sides. I wanted to serve ASRA, but I also had to build a department, and I was recruiting. So I think that was perhaps the biggest juggling piece of that 12 months. If I'd been well established in my department, I'm sure I could have given much more to the society than I probably did.
Thank you. What changes in thinking, practice, or other perspective around ASRA do you think you fostered during that time of your association?
Oh, I think the education of young people is the most important. All the young residents and fellows can benefit from what the society can do for them, not just in education, but by encouraging them to look at their own work and see how that can be improved by research, even to the extent of perhaps leaving clinical practice to go into full-time research. This was the message that needed to be conveyed at all of our meetings. And so I think our meeting agendas became very good. There were times throughout that period, and I suppose just to go back to the last question you asked me about my time in ASRA when I started, we had some difficulties with the administration. We had originally done very well with a very dedicated executive administrator, John Hinckley, but the administrative service that provided was not efficient financially. So we did have some ups and downs. And obviously, without getting our financial matters under control, we would not be able to do the other things, which is why we became a society that we are. So it's the education, promotion of research, and moving the goalposts further out, so that there are going to be other ways of looking after pain control that may not be just using a needle by itself. So I think that message needs to be, it's maybe uncomfortable if one is comfortable doing things the way they've been doing them all along, but one needs to become somewhat uncomfortable in order to accept new ideas, which may shatter the previous held concepts on which one is practiced.
Thank you. So if I ask you, in what words would you like to describe and the present day ASRA pain medicine as a society?
Magnificent. I think the incorporation of pain medicine has been so successful. It's given the society lifeblood now, so that it can go on for as long as we're around and beyond. But I think also the place for regional anesthesia within that context of pain management, both acute and chronic, is why the society is so successful and is looked upon by other societies, I think, in the same light. I think the meeting numbers reflect the success of the society too.
Thank you. And my last question would be, are there anything else about ASRA pain medicine as a society and its contribution towards the larger anesthesiology and pain medicine that you feel needs to be highlighted and taken forward? Any last thoughts?
Well, yes, we still need enough dedicated, well-trained regional anesthesiologists to go into, in particular, academic departments where, unfortunately, regional anesthesia has fallen into the backwaters in many places because of the little extra time which is not allowed for regional anesthesia, the excellent general anesthetics, which is so quick, on and off, like a light switch, and yet I think the research that has demonstrated how much regional anesthesia can benefit the patient outcome by the improved morbidity against the use of general anesthesia, that unfortunately gets lost in the dust in a lot of these places. I think simply because there aren't enough disciples around to keep pushing it. What I think Danny Moore demonstrated this so well at the Virginia Mason, doing anesthesia for a very, very busy operating room. There would be as many as 12 patients in a pre-operative area, all with different blocks, multiple intercostal blocks, epidural blocks, spinal anesthesia, sheath blocks, intraplanar blocks. They would be all there ready to go straight into the operating room. There was no waiting of the surgeon for their patients. In fact, in many ways, by starting far enough ahead of the surgical schedule, one can plan to do this. But again, it requires the individual who's enthusiastic, who can work with surgeons and just show them how much better a particular regional anesthetic procedure might be for what they're going to do over general anesthesia. That's still an unfulfilled area because we don't have enough as I said, disciples around to be able to do that.
Thank you very much for your time, Dr. Hicks.
Thank you. Thank you very much.